So first of all, thank you so much for the very kind invitation to speak today at the HPSN meeting. As you know from Stefan, my name is Walter Eppich, and I'm the professor and chair of simulation at the RCSI Sim Center for Simulation Education Research at the RCSI University of Medicine and Health Sciences in Dublin, Ireland, where I've been working now for just over a year. Before that, I was based in the United States, and it's been very exciting to be in Dublin and also to begin collaborating with CAE. More about that in a moment. The topic I'm going to be exploring today with you is learning through talk, which has been a big area of passion for me. And what we're going to do is we're going to explore the synergies between learning through conversation in simulation and learning through conversation in the workplace. And I'll be unpacking this a little bit more as we go through our time together. My Twitter handle is @WalterEppich if you're interested in tweeting. So some disclosures. I get some salary support from the Harvard Center for Medical Simulation and some other entities to do simulation educator development. And I'd like to offer an acknowledgement and appreciation that RCSI Sim aims to improve patient safety, education, and research through experiential simulation-based learning, and that RCSI Sim and CAE Healthcare collaborate formally to enhance healthcare education and research and to improve patient safety through simulation. RCSI Sim is a CAE Center of Excellence, the first of its kind in Europe, and that relationship began in August of this year. And RCSI Sim receives unrestricted funding from CAE to support its educational and research activities, and we're very grateful for that, so thank you. Also, portions of the work presented here are supported by the Irish Higher Education Authority Innovation and Transformation Program under the grant you see there. All right, so let's launch into it. I became interested in conversational learning about a decade ago during my work as a pediatric emergency physician. One night, it's 3 in the morning, it was pretty quiet, and a child was brought back from triage who was quite unwell. This was a child who was 3 or 4 years old, who had an extensive surgical history with all kinds of hardware and technology dependency, central line, ostomies on the abdomen, and the child had a very low body temperature, about 34 degrees centigrade or 94 degrees Fahrenheit roughly. And we were very concerned that the child had a sepsis picture. And so as we began stabilizing the patient, I turned to one of the resident physicians or SHOs and said, I need the surgeon to come now. And the thing that was very intriguing about this situation is that it seemed like a minute or two later, and that surgical resident was standing behind me, or the surgical registrar was standing behind me. They came immediately. And I became very intrigued by how this resident communicated the urgency to this surgical registrar. Because as many of you in the audience will know, I presume many of you are clinicians, it's not something that is automatic, that when you call someone for help that they immediately come. And so after the patient was stabilized, had gone up to the intensive care unit, I asked the resident, so what did you say to that surgical registrar to get them to come right away? And she said, well, I called them and I said, listen, we have this 3-year-old child. We're very concerned she has sepsis. She's followed very closely by this particular chief of surgery. And then with that, the surgery registrar said, I'll be right there. So there was something about providing just the right information to convince the person to come. And that really led me down this path of research that I'm going to tell you about right now. And I hope that this will have some practical implications for your own educational practice. So our main questions for the next hour or so will be, what is talk? Why does it matter for clinical education? And how can simulation and workplace talk inform each other? So what is talk? Talk has many different terms that are used in the literature: communication, conversation, discourse, dialogue. And in its essence, talk is what we say in terms of the verbal and nonverbal content and its social implications. So for today, we'll define talk as joint social activity. Now, because of how we communicate with each other is so important, it's actually part of the work that we do, and it's also part of the experiential learning that we engage in. So in experiential learning, we often talk about learning by doing, when in actuality, much of this is learning by talking. And as I mentioned, talk is then viewed as work, presenting to patients, giving handover, and this sort of thing. And so there's been a huge focus in health professions education to view talk as a communicative competency. We assess people and how they communicate, and any number of professional and societies, such as CanMeds, for example, in Canada, or equivalent organizations in other countries, certainly the GMC, I would imagine, have competencies around how people communicate. And what that does is it focuses attention on talk as a competency and detracts away from another important function of talk, which is talk is a social medium of learning. It's how we learn through interaction with each other. It's this joint social activity. And if I think for a moment about two metaphors of learning that Anna Safard articulated just many years ago, we can think of learning as acquisition, sort of acquiring knowledge, or we can think of learning as a participatory activity. And really, I tend to view learning as something that we engage in through participation in communities of practice, so to speak. And so if you take that lens, the talk that we engage in not only mediates the learning, but it enables the patient care in team-based settings. No one works in isolation anymore, and we must communicate with each other. And one of the fundamental aspects of that is that team communication, how we communicate with each other day to day, is how we learn with, from, and about each other. And unfortunately, we know that communication breaks down, and it's been reported in many studies that when communication breaks down, patient care breaks down. This is across sectors, not only healthcare, but also aviation and other high-risk areas. And what I'm going to submit to you today is that when communication breaks down, not only does patient care break down, but learning breaks down. And I think that's a really important piece. And all of these aspects are interrelated. So the good news is that we can steer the talk of practice. We can influence this. You can influence this through how we structure, for example, interdisciplinary ward rounds. And there's lovely studies that I summarize in a book chapter that look at how you structure interdisciplinary ward rounds and bring people together in time and space and structure how they communicate that improves patient safety and reduces preventable adverse events. Checklists are a really important way of structuring the talk of practice. Just think about the WHO surgical checklist. Handoffs are another really important part about how we can structure handoffs in order to promote patient safety and reduce preventable adverse events. And I'll just point you to the work of Amy Starmer, who really published a whole series of papers as part of her research program into handoffs, culminating in a New England Journal of Medicine paper where they looked at the approach to training pediatric residents or pediatric SHOs to use IPAS, a particular handoff mnemonic and tool, and reducing really preventable adverse events. And then, of course, there's simulation, where we have the opportunity to help people learn how to speak with each other and to speak more clearly to create shared understanding. And of course, we just think of debriefing as a way of steering the talk of practice. And we spend a lot of time thinking about how we debrief. So more about that in a moment. But why does this matter? This matters because it influences how we design curricula. It influences how we develop faculty. It influences how we support learners. And it influences how patients ultimately receive the excellent care that we seek to provide for them. And so for the rest of my time with you, we're going to unravel each of these things in turn, and I'll make an argument for you why talk matters. So the overarching question that we'll be answering today is, how does talk contribute to learning and clinical education? And we're going to take two particular vantage points. One, which is learning through talk for practice, so preparing for practice, the type of learning that we do in simulation. And then learning through talk from practice, which is the learning that happens on the ground, day to day, on the wards, in clinical practice, that may be a byproduct of patient care activities. So we're going to look at each of these vantage points. And so we're going to focus on certain aspects of talk, namely healthcare debriefing, which is perfect because we're a healthcare simulation audience here today. And then from the workplace, we're going to look at telephone talk and team reflection, which I'll unpack much more to follow. And what we're going to do then is we're going to try to identify synergies. How do these aspects of learning and these learning venues interact and synergize with each other? So let's start with healthcare debriefing. So what are debriefings? And I'm sure this is not new to any of you in the audience, but debriefings are nothing more than conversations. Conversations that generally occur after a simulated event or an event on a ward. And they are conversations to make sense of events, to understand what was working well and what we should continue doing, what we might need to change, to understand why people did what they did and what their rationale for action was, and perhaps craft new ways of thinking. Early days when I became very interested in debriefing, probably about 10 or 12 years ago, the literature was very much focused on the process of debriefing or how to debrief. And most of the papers on debriefing that were published were about specific debriefing models. And what they did, however, was they neglected the content of the debriefings, namely the what to debrief. And increasingly, we're learning that what's important is the context of where and when and with whom these debriefings occur. And it's this balance between attention to process and content that really highlights the quality of a debriefing. And Christian Crow, one of my friends and colleagues from Denmark, had a lovely paper where he talked about artistry in debriefing. And really, this is about adapting to the context to make it work for your learners. So just to give you a little bit of a trajectory of some of the work that I've been involved in, I collaborate very closely with Adam Cheng and others, and we did a systematic review on debriefing earlier in the decade, and we found in this really extensive work that there's a lot of variability in practice, which doesn't surprise at all because the contexts differ, and that in many ways details are underreported, and we called for more research. So we began doing some of this work ourselves. And one of the things Adam and I did is we articulated a blended approach to debriefing that we call PEARLS, which is really a lovely acronym that fits to what we're going for in simulation debriefing, which is hunting for pearls of wisdom, so to speak. And we focused on post-event debriefing here. And what we articulated was that there are multiple educational strategies that we can blend together into the analysis phase. So all of these process papers that focused on different debriefing models, which make people's heads spin, they actually have a lot of commonalities. And what we did is we blended an approach in the analysis phase that looks at, for example, learner self-assessment, an example of which would be plus delta debriefing, focus facilitation strategies that hone in on a particular aspect of the performance during the simulation. And you think about something like advocacy inquiry as an example of a focus facilitation strategy. Hey, let's talk about this. This is what I saw. This is what I think about it. What do you think? That's an example of focus facilitation. And then, of course, we often provide information in the form of directive feedback or teaching as well. And what we did is we tried to articulate how one might adapt debriefing to context depending on what the performance domain is, meaning what the content would be of the debriefing. Who are your learners? Are they more interprofessional, experienced clinicians, or are they early career, perhaps undergraduate learners? And we provided some guidance for that. And there also is a debriefing script, but really the heart of the PEARLS model is this blended approach and providing guidance for that. To take that a step further and to look at a specific context, we in 2015 wrote a paper about structuring feedback and debriefing specifically towards achieving mastery learning goals. And this looked at feedback and debriefing in resuscitation education. And here specifically, we looked at what happens when people are doing a simulation and then are doing little micro debriefings during advanced life support scenarios. So again, so this is embedded within resuscitation education, which is something that many of you may be involved in. Classically, one would do a scenario for 10 minutes, a resuscitation scenario, and then debrief for 20 minutes. And really what we did here is we looked at some papers that had previously been published using mastery learning and rapid cycle deliberate practice. And we invited people who were involved in those initial studies and doing the education, namely Elizabeth Hunt, Betsy Hunt in her rapid cycle deliberate practice, and Viva Jo Sadal, who did all of the advanced life support training at Northwestern University, where I used to work, and had amazing results with advanced cardiac life support. And what we learned in really unpacking their approaches is that they did what we called micro debriefings. So they would do either pauses in the scenarios and do little cycles of debriefing and then resume the activity and allow people to apply their learnings in a feed forward way. Or they would do very tiny scenarios, short scenarios, and do lots and lots of cycles of them. And so what we articulated here is that how you approach feedback and debriefing is highly contextualized. And I would argue that if today you're doing resuscitation scenarios that are highly algorithmic in nature, and you're doing 20-minute debriefings, that's probably not the best way to do it. And the evidence doesn't really speak towards that. To take that a step further, I was really grateful to be involved here in this 2018 project and paper looking at resuscitation education science, again, led up by Adam Cheng and others. And you'll see some familiar names there, Betsy Hunt as well. And what I was leading the feedback and debriefing working group here. And what we articulated here is that for feedback and debriefing and resuscitation education, the timing of these debriefings, the process and the content are all incredibly important. And so this aspect of pausing, providing some feedback, having some debriefing, and then resuming the action is a recommended strategy. And that the other thing we layered in here is that performance data is vitally important. So it's not you just sharing your perspectives as an educator, it's also showing hard data about, for example, chest compression rate, of how long it took to resume chest compressions after a shock, for example, or the pre-shock pause as an example. Betsy Hunt, in a lot of her work, talks about no blow fraction when you're not bagging, no flow fraction when you're not compressing, these sort of things. So when we think about, so what we've talked about up until this point is debriefing as a learning conversation that's structured and balances process and content. We talked about pearls as a model that blends various approaches within a single debriefing for post-event situations. And we also took a look at resuscitation education and how we need to be really tailoring our approach for that context. But I will just pose the question, then what enables debriefing conversations irrespective of context? And I think we know increasingly what's very important here is that we need to establish what Jenny Rudolph calls a safe container for learning. And this is a part of the pre-briefing, the establishing psychological safety. And again, psychological safety is really a sense of, or a belief that you won't be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. And you are able to engage in risk-taking, interpersonal risk-taking. In part, this is about managing rapport with your learners. And the one thing I like to emphasize is that the debriefing, the foundation for the debriefing begins the minute that your learners show up in the simulation center, or even when you begin any contact with them via email or in any form, because that's setting the tone for how this safe container will enable risk-taking. And 2 years ago, I collaborated with Michaela Kolb, again with Jenny Rudolph and others, Adam Cheng, to talk about psychological safety in debriefings, which is really a dynamic balancing act. And we call it dynamic because psychological safety isn't a set it and forget it entity. It's something that requires management, cultivation, and perhaps even strategies to regain psychological safety. By the way, at this point, this slide serves as a reminder. What I'm going to do is put together the key slides and share them with Jamie, and he can post them or share them with conference attendees so that you can, as a sort of your own learning curriculum, pull some of these papers if you aren't familiar with them yet and have a look at them. So no need to take notes. I will share the key slides with you. Further, we articulated really a framework for how people develop debriefing skills that is a journey from discovering, growing, and maturing. And what we did is we aligned our framework to the Dreyfus model of expertise development, where you begin with being a novice, advanced beginner, proficient, competent, becoming an expert in your field. And really what this is about, it's about being artistic and adaptive to context. That's the hallmark of a mature debriefer who can really adapt to contextual challenges and has adaptive expertise. And in this paper, we articulate several strategies that also align to faculty development approaches that can help you perhaps accelerate the learning curve, so to speak. This also relates to how we engage with more early career debriefers to help them improve, or how we help each other improve. And this is, I think, a helpful paper that talks about coaching the debriefer. So a lot of these conversational learning strategies within simulation have multiple layers. There's the debriefing that occurs for the learners. There's faculty development and simulation educator development that occurs to develop debriefing expertise. And peer coaching, which is a form of peer learning, is a strategy that can also promote workplace faculty development. And I think many of you will be aware that a lot of the faculty development that occurs happens on a course or at a conference. It's a so-called event that's occurring. But a huge part of faculty development also happens on the ground during educational activities, workplace faculty development. So we're teaching a real course with real learners, and we're working with people who are coming along and developing expertise, and peer coaching is a really valuable way to support them in their learning. So when we think about all of these learning conversations, we realize that feedback, debriefing are actually quite similar, although historically they were not. Here's a paper from last year with Walter Tavares and some pretty heavy hitters in the feedback literature, including Chris Watling, Joan Sargent, and the like, and Pim Tennyson, who's one of my own close research collaborators. And what we did here is we looked at the words feedback and debriefing, and we looked at where these words have come from in our understanding in health professions education. And feedback, really a decade or 20 years ago, was really all about information. How do I tell someone what they were doing to help them get better? So it's just telling them, giving them information. And debriefing, on the other hand, was coming from a place of guided reflection to promote new insights through perspective sharing. But as we traced these terms through the literature in our sort of synthesis of the literature, we realized that all of these things are learning conversations about experiential events in workplaces and simulations. And actually the feedback literature itself looks very similar to debriefings. There's debriefing feedback models out there that really look at developing rapport, exploring reactions, exploring content, coaching for change, to give an example of Joan Sargent's R2C2 model of debriefing. So there are really so many commonalities here. And it's these commonalities between workplace and simulation conversations that we're exploring today in this talk. A couple of years back, we articulated some of these lessons that we can take from healthcare simulation and apply them to clinical event debriefings and coaching conversations, because simulation and workplace have a lot of parallels. have a lot of parallels. So I'd encourage you to have a look here. What I'd like to do now is transition from simulation education and healthcare debriefing and talk really about workplace conversations. And the first workplace conversation will be telephone talk. And I'm just going to pause for a second and have a sip of coffee since it is 5 a.m. in the morning. So as I said, I became very interested in telephone talk about a decade ago during one of my shifts. So we decided to study the intrinsic learning potential of telephone conversations. And we did so here in this paper, Learning the Lingo. And we decided to look at this because we know that resident physicians or SHOs, even people who are early in their career, spend a lot of time on the telephone. You know, our families often think we spend time talking to patients, taking histories, doing physical examinations, or other activities depending on your health profession's background. But actually a lot of time is spent talking on the telephone. Certainly where I used to work in the pediatric ER, a resident would go into a room for 10 or 15 minutes and might spend the next hour on the telephone, calling consultants, calling for advice from different specialists, getting the patient admitted, talking with the inpatient team, talking to the intensive care unit and the like. So what we were interested in here in terms of telephone talk was work-related telephone conversations. So all of those telephone conversations that occurred to advance patient care objectives. So our question was, how do these work-related telephone conversations contribute to clinical education? And what we did is we did 17 in-depth semi-structured interviews with a range of trainees from pediatrics, emergency medicine, surgery, internal medicine, at different training levels from several months after medical school to 8 years out of medical school. We used what is known as constructivist grounded theory, which is a specific qualitative methodology. It guides how we collect and analyze data. And we used a sociocultural lens. So as I said at the outset, we know that talk is joint social activity, has a lot of social implications. So we took a sociocultural lens, knowing that in this view of how learning occurs from a sociocultural perspective, interactions are vitally important. By the way, people often ask me, Walter, why didn't you analyze recorded conversations? And that's a really good question. That would have been a different research approach to do this study. We were, however, very interested into what the residents were thinking, their perspectives on these conversations, and their motivations. So we wanted to hear not only what they said, but what they were thinking about these conversations. So what we learned, not surprisingly, is that these conversations have positive influences on learning. That means people spend lots of time on the telephone doing the busy work, getting people admitted, getting advice on the phone, but this promotes their learning. And it promotes their learning because of something we call productive conversational tensions. So these are unpleasant moments on the telephone where they're feeling unsure of themselves, where they perhaps are dealing with people who are up the food chain, so to speak. But these conversational tensions are productive because they motivate learners to change what they say and how they say it to become increasingly concise, more focused, and the like. And I'll be giving some examples of this as we go through the presentation. But these are productive conversational tensions because they motivate people to change what they do. So when we think about the conversations that are happening, the residents or fellows or SHOs or registrars are talking with whomever, a nurse, a consultant or supervising physician, a subspecialist. And these conversations are happening in a patient care context that governs what they say and why they say it. And they are experiencing tensions that are related to power differentials. So let's say an SHO is speaking with a consultant or a subspecialist, or they're experiencing pushback when someone, and pushback is when someone says no or is disagreeing with you without really considering your perspective. It's sort of like pushing back strongly and not really listening to you, or they're uncertain. And this is the hallmark probably of more early career trainees, is that they're often unsure of what they're doing. And the reality is we're all often unsure. There's uncertainty that pervades clinical practice. And the question is, how do you convey your uncertainty, but also still embody trustworthiness? And what we uncovered in our study is that these residents, fellows, SHOs, and registrars, they manage these tensions in the conversation. They manage the tensions of the power differential, the pushback and the uncertainty in what they say and how they say it. So what they say is the medical content, the social content of the conversation to build rapport, to how to get things done. These are all really the content of the conversations. And how you say it is the rhetoric of it. How do they craft an argument that they can be convincing, that they can be persuasive? Much like that resident with that potentially septic child that I described at the outset of my talk. She got on the phone and she crafted a very short communication that included just the right things and convinced the surgical registrar to come immediately and drop whatever he was doing to come now. And that is quite a skill. And what I learned through my study is that, of course, that's something you learn how to do. That's not something you're born able to do. And it's through the productive conversational tensions, when people don't buy into your point of view, that you learn to craft your argument and focus what you say to get what you need, get what you want, get what the patient needs. So some of the things that people described is the first substantive sentence you say on the telephone call is critical, because people won't listen until you know what you're listening for. Hey, this is Walter. I'm calling about a child here in the emergency department. It's a 3-year-old child with an extensive surgical history, and we're worried the child is septic. That's the substantive sentence. Participants in my study also stressed that they needed to learn the lingo, to paint a picture, and to use the buzzwords that really grabbed attention to convey information and urgency, both concisely and persuasively. So if I'm talking to a surgeon, I need to paint a picture and use these buzzwords that will grab the surgeon's attention. By the way, we've talked about conversational tensions, and I think the thing that was a contribution of this paper is that often in the literature, tensions were framed as being negative, and tensions can be quite negative because they're unpleasant and they can be unproductive. So beware, we're not intentionally creating tension. This is definitely not one of the findings of our work. Unproductive tensions are related to incivility, disruptive behavior, and bullying, which is nothing that we're striving for. So please beware, these productive conversational tensions come up without any deliberateness to them. They're just there because of how we work with each other. We're not trying to make tension. As an extension of this work, we reanalyzed our data and used it as an educational needs assessment. And we did a thematic analysis of these 17 interviews to say, how could we help these junior or early career physicians learn better? And by the way, I know I'm focusing here on young doctors in my study. A lot of these messages are applicable for other health professions, but for the purposes of research, I focused on a single profession. And in this secondary analysis, we found that junior doctors need a lot of training, and often they don't receive any training at all in how to speak on the telephone. Common challenging situations that we heard again and again was calling for advice of subspecialists or calling your supervisor. So think about the SHO who's calling the registrar, or the registrar who's calling the consultant at home. And one of the big things was how to structure the presentation succinctly while also conveying urgency in a convincing way. And I think from many of the people in our study, we heard that people would talk, junior doctors would talk, and only at the end of several minutes later say the most important piece of information. So for example, we heard that, junior doctors often give rambling presentations in which the severity of the patient's condition can get lost, with the result that nobody's going to pay attention. So it's like, get to the point already, right? This is what's going on in your thought bubble when someone is rambling on the other end of the line. And this is a common phenomenon. I'm sure many of you in the audience will experience this. Or early career doctors often present irrelevant information while paradoxically leaving out critical details. So they tell you everything because they don't want to forget the things that are important. So if you really don't know what is important, you're going to tell me everything, which maybe I don't care about. I care about the important things. And I think this is part of how junior doctors learn through conversation. It's a trial and error approach over time that they learn what to focus on, what to say first, what to say second, what to leave out, and only offer when someone asks follow-up questions. Right? And so if you're on the receiving end of the line, you're like, I don't need all this detail. Just like, tell me the important bits. So one of the things we found also was what helps junior doctors learn. And of course, there are explicit teaching and feedback practices that could support how junior doctors talk on the telephone. That's not the revelationary finding. What was, I think, more interesting, oh, and by the way, part of that is also sharing the why. We heard that from a lot of the junior doctors. When more senior people share the why behind their recommendations. So it's not only do this, but it's do this and here is why. When they share their train of thought, they really appreciated that. So it's not only telling you what to do, but telling you what to do, and this is why we're doing it this way. And this is also relevant for faculty development. How do we help clinical supervisors work with junior doctors who are rambling on the telephone? For example, how do you interrupt someone in a way that's respectful, but like helps you move things along? One suggestion, by the way, is if I'm on the phone with someone who's rambling, I would say, can I just pause you a second real quick? You said a lot of things. Let me just summarize what I've heard. Or I've heard you say a lot of things. What's the most important thing right now? Or I've heard you say a lot of things, but I've not heard a clinical question from me. What is the reason for this call right now? So can I push pause? The other important thing here is that there are a lot of informal aspects to these conversations. The informal conversational interruptions and questions that play a really vital role. And these are not, we're not intentionally interrupting people. What we're doing, it's sort of the natural ebb and flow of conversations where you sort of interrupt with follow-up questions and say, what was the fever? Or I didn't hear that. Or you sort of correct some of the things they say in conversation that helps them learn what they need to be saying. So for example, these informal conversational interruptions and questions are actually disguised feedback. And even if the listener on the other end of the line isn't thinking, I'm going to give them feedback right now, it is feedback for these learners. They're learning, okay, maybe I should say something, should tell the reason of the phone call right in the first sentence. So when they get interrupted and someone says, hey, why are you calling me? The reflective junior doctor will say, you know what, if they're asking me why they're calling, then I need to tell them early on why I'm calling them. And this idea of disguised feedback made us realize that these informal conversational interruptions and questions occur all the time. And if we sensitize learners to them, perhaps we could help them learn how to learn for the workplace through their simulation-based activities. So let's for a moment think about the paradigms of simulation. The classic one is learning how to perform. So I prepare in simulation for something I'm going to do in clinical practice. And what we're saying here is maybe there's another complementary opportunity, which is preparing learners to learn from their clinical practice. So if I'm thinking about learning how to perform, I can teach people to use a structured approach on the telephone. There's lots of models, right? I can use a checklist. Hey, use this approach. Use SBAR. Use the 5C approach. And many of you know SBAR already, right? Situation, background, assessment, recommendation. But what I'm saying here, I could say if someone's interrupting you on the telephone and saying, hey, why are you calling me? What they're telling you implicitly is, give me a framing statement up front that says, hey, this is the reason for the call. I'm calling you because I have a kid who's septic and I need your help with this. Or, hey, listen, I have a patient here. I'm worried about acute appendicitis. I think they're going to need a surgical management. So one of the big messages here, I think, and implications for your work as simulation educators would be to integrate telephone talk into existing simulations and include that aspect into the debriefings. Just to give you an example, where I used to work in Chicago in our children's hospital, we would always, at the very end of the simulation, let's say the team is assessing a critically ill child, we would include a telephone call to the pediatric intensive care unit. So, and they would have to sign out the patient to the critical care doctor on the other end of the line. And that telephone talk actually would give a biopsy of their understanding of the case. So I would encourage you to integrate telephone talk into existing simulations as one very pragmatic thing you can do going forward. One of the reasons why this is important is this relates to feedback literacy. And feedback literacy is helping people make sense of the feedback that they're getting. So the understandings, capacities, and dispositions learners need to make sense of information and use that information to enhance their work or learning. And this is exactly what this disguised feedback is about, right? Feedback is all around these learners in the workplace, and we're helping them make sense of that so that they learn from that feedback, right? So just to give you an example from the telephone talk, if I'm a junior doctor and I'm calling, and I have a patient who's had fever for 3 weeks straight, every single day, and now they're in the emergency department, and I'm calling the infectious disease specialist, and the infectious disease specialist is now asking lots of follow-up questions to my presentation, such as, have they traveled anywhere? What's their immunization status? Do they have any pets? Have they been in any area where there could be tick-borne illness? Those questions are actually implicitly telling the learner, you need to include these things in your presentation right up front, right? So it's about reading the feedback that's presented to them. Liz Malloy, who's an educationalist from Melbourne, Australia, really has talked a lot about feedback literacy, and it's how can you help learners identify what helps them learn? And by the way, we're focusing a lot of our research on feedback practices in simulated patient or simulated participant methodology. And I think that's a really important aspect. So it's not only can SPs give feedback after an encounter with, let's say, an undergraduate medical student, but how do SPs approach their role portrayal to perhaps offer disguised feedback? So what we're doing at RCSI with our research group, and this is part of the work that's funded by the Higher Education Authority in Ireland, is we're doing a scoping review to really understand these feedback practices, and we're collaborating with international experts from the Wilson Center and from Australia to do this work. Another study we're doing is we're looking at simulated participants or simulated patients within healthcare and trying to understand how they approach this. And last but not least, we're doing an interview study with educators from various sectors, not only healthcare, but law, teacher training, and first responders, to see how they conceptualize simulation and how do they really bring these simulations to life, and specifically around the feedback practices. So there's a lot of really interesting work ongoing. So I just would wish for you to stay tuned. But again, the focus here is all about the conversations and the potential of those conversations, both explicitly and implicitly, to influence how people improve and grow and learn. So we've just getting into the final parts of the talk now, and I know there'll probably be some questions. Team reflection is another important aspect of this work, and how do people talk and reflect on their performance with each other? So if we take a step back for a moment, we know that Jenny Weller talked about this already almost 10 years ago, that there's a lot of tribalism in healthcare. There's an us versus them mentality. We're the ER doctors, they are the ICU. We're the ER doctors, they are the surgeons. We're the doctors, they are the nurses. So there's an us versus them. And really, when we have this us versus them, either we're in the in group, in the us, and we think we're the cool kids. We view our traits as favorable and more desirable versus them, who tend to be less than or other. And I think this us versus them mentality really leads to a lot of patient safety risks, because it impairs how we talk to each other. So if we could imagine, if we could look in the crystal ball and see what would help here, I think it would be to move from them to us and to really bridge these boundaries and move from them to us. And team inclusiveness is sort of an emerging idea that I'm developing. And I'm so excited about it. And I'd like to share a little bit more about team inclusiveness with you. And I'm hoping you'll be inspired to integrate some of these notions into your team-based simulation activities. So when we think about what would comprise team inclusiveness, there's inclusive leadership, inclusive leader language, and team reflection, which I'll take a deeper dive into in a moment. But inclusive leader language is really something that Amy Edmondson and Nembard put forth some time ago. And it really is about inviting and appreciating others' contributions. So someone who's engaging in inclusive leadership says, I'm going to need your help and ideas. Please let me know what you think. And when someone chimes in, you appreciate their input rather than, no, that doesn't make any sense. Or thanks for that suggestion. I think that's not the top of my list, but maybe we'll put it on the back burner for the minute. I really appreciate you letting me know that. And then Mona Weiss and Michaela Kolbe and others did a lovely study where they looked at the use of inclusive leader language. They did a simulation study where if leaders used inclusive language, then out-group members would, meaning nurses, if they're working with physicians, would speak up more, or implicit language for in-group members. Again, inclusive leader language is we, us, our. So it's not what are you going to do about it, it's what are we going to do about it? Or how are we going to proceed here? What is our next step? Not as what is your next step? And this very subtle difference enables in-group members, so other physicians, for example, if I'm a physician, to chime in with their suggestions so that it promotes speaking up behaviors. And we know from clinical practice that we need people to speak up and share what they've seen, what they think, even if they're not sure, because that's how we capture patient safety risks. And then lastly, team reflection. Team reflection is how a team reflects together collectively on their goals, strategies, processes to improve current and future performance and adapt accordingly. And Jan Schmutz is a psychologist, work and organizational psychologist from Zurich, Switzerland, who he and I have developed these ideas, and I'd like to unpack that for you now. Typically in the literature, team reflection or team reflexivity was described as being something that occurred after an event. We call it post-action team reflection, and it's really like a debriefing, which is something we've spent a lot of time talking about. But these same reflective processes can occur before an event. Think about a huddle or a briefing before a major event. Think about a trauma patient who's coming into the emergency department, and you get a radio call that the patient will arrive in 10 minutes. And now you spend those 10 minutes huddling with your team, thinking about what could be the main issue. What do you need on equipment? Who's going to do what? And then, of course, there are these same reflective processes that can occur in action during the event. And these are characterized by recapping, summarizing, and inviting input. The goal of all three of these processes that we articulated in our paper is about developing shared understanding, shared mental model, and approaches to adaptation. So we took a closer look here at the inviting input, and what does that inviting input look like? And this is the fundamental aspect of team reflection. It's not only recapping and summarizing, but it's recapping and summarizing and then inviting input, which is the reflective moment. So we have a 3-year-old child with high heart rate, fever. I'm really worried that this is sepsis. What else could be going on? What do you guys think? What might we be missing? What else could be going on? So another clinical example, just to illustrate these ideas, could be, let's say you have a patient, whatever the age, who's intubated and is now having lower oxygen levels. And you do all the basic things, make sure the oxygen is connected. You go through your dopes, acronym, right, to see if it's displaced, obstructed, all those things, to see why could the oxygen level be remaining so low. And as a leader, you might say, okay, guys, we've done all the obvious things to see why the oxygen saturation is 85%. And I'm confused as to why this is staying so low. What could we be missing? What other ideas do you guys have? So it's inviting input from the team. Now, why is this important? Or if you have any other suggestions, why is this important? In another study, we showed using a simulation study that it improves clinical performance, especially in larger teams. These reflective behaviors, again, that might only last for 10, 20, 30 seconds repeatedly. You might know of 10 seconds for 10 minutes. This would be a classic example. It improves clinical performance. As an extension of this work, Jan and I and another collaborator developed a behavioral observation system, something we just published this year. So we developed a system of assessing these in the moment team reflection behaviors that are really about seeking information, evaluating the information, interpreting it, and then planning next steps. And all of that is related to our theme of talk, because these aspects are all team communication events, right? It's something you can see on a video, you can listen to. People are communicating with each other to develop the shared understanding. So stay tuned to this space. There's a lot more research ongoing. And what I'd like to do is just give you an example about how this team reflection has applicability in other environments. And I have a lot of time for Antarctica because I went to Antarctica 3 years ago. There I am on the left side waving from the boat. We were on King George Island, which is a smaller island that belongs to Chile. And we asked ourselves in our research that we did there, when we were looking at the Antarctic research teams, what enables them to adapt? And we did a rapid ethnographic approach. We went down for almost 10 days and observed people during their field missions. We went out into the field. We went into the boats. We went into the hikes with them because they're collecting samples to do, I don't know, global warming, climate change research. We attended their formal meetings and spent time with them informally too. By the way, the reason why this is interesting is because the work that they do, the research teams in Antarctica, is high risk, right? If they're going to a glacier to collect samples of ice, if you suddenly fall and slip into a crevasse, you die. Or they dive to the bottom of a body of water at certain coordinates to collect soil samples. And the water is 2 degrees centigrade. So if there's an issue there, that's potentially life-threatening. Or if you encounter a leopard seal, which is a predatory animal which tries to pull you down and pull off your equipment, that could be quite dangerous. And so we did 46 semi-structured interviews over the past several years, and we're analyzing and putting out the first papers. And we interviewed these research teams and the logistics staff. And here were the 3 stations we spent time at. And we had some initial lessons that were really relevant for healthcare that I'd like to share with you. First of all, social cohesion and relationships matter. We need to build trust. Knowing that your team has your back is incredibly important. And that we learned there that these teams in Antarctica prepare for critical events long before the critical event. And that occurs during the informal time, the hanging out, meals, social activities, and the like, and that they are briefing and debriefing both formally and informally constantly, calibrating their performance and their perceptions and developing shared understanding and preparing for these untoward events that might occur, equipment failures, weather changes, and those sort of things. And finally, this reflection in the moment, this reflection on the fly or in action TR is essential and helps them adapt. So if we put these pieces together, and this is something that we're doing with our research program at our CSI Sim with our team, is that we're really focusing on working better together and learning from each other. So we're taking a design-based research approach for much of the work that we do. And design-based research is nothing more, sounds quite simple, of designing an educational intervention or modifying an educational intervention based on some sort of theoretical understanding, implementing it, evaluating it, what worked, what didn't work, doing it again, evaluating it again, and then doing it again and evaluating it again. So it's this iterative cycle of designing, implementing, evaluating, designing, implementing, evaluating, which may be a cycle you recognize from your own work. But design-based research has two main aims, which is to mature the intervention, to make the educational intervention better, and to advance theoretical understanding. So what we're doing is we're really focusing on interprofessional collaborative practice. And the context that we're focusing on are child safeguarding or child protection. We just implemented a lovely course with social workers, nurses, physicians 3 weeks ago. And we're also very interested in acute child mental health crises, because these are the types of crises that require an interdisciplinary response. And because of the highly social nature, we're using sociocultural learning theories as a foundation to design and evaluate these courses. One of the things we're also very much interested in at RCISM, and one of my dear colleagues from RCSI, Dr. Claire Condren, who's our Director of Simulation Education, has a very keen interest in peer learning in undergraduate medicine. One of the problems in a lot of you simulation educators may face is that you have a lot of learners who need to go through and engage in simulation. And one of the strategies that we're working on at RCSI is to help medical students support each other, perhaps through video review, video critique, peer feedback, and the like. So stay tuned for that. I think this is a really exciting space in healthcare. So one of the things that is really coming out in our initial work is that language is what drives the shared understanding and mutual respect. The way we talk to each other matters. And it's just a little drop, little words can send a ripple effect throughout your team and really influence learning. So I just have 2 more slides and really want to put it together. And I promised you to explore the synergies between sort of formal educational talk and workplace talk. And really the synergies surround the fact that words matter. What we say influences how we learn, and it influences how patients receive care and whether that care is safe or whether we put them at risk. So some of these synergies relate to the context, right? Talk is all about the context we're in. Who's involved? What is the issue? How much time do you have? Is there urgency? Psychological safety, which enables risk-taking, is valuable as are relationships and rapport. One of the things I touched on with the work in Antarctica is that social cohesion is so important. And we know in healthcare that that's not necessarily the case. Often we come together in teams and you don't even know who the other people are. And it's a high stakes situation and someone's life is on the line. So we need to really think about how we foster relationships and rapport. These conversations balance both process and content, structure and strategy. We know that in all contexts, framing is a really important strategy. At the beginning of a conversation, at the beginning of a line of questioning and debriefing, to say, hey, listen, let's talk about this, or this is why I'm calling, so that people know what the conversation is about. And we know that productive tensions promote learning because they motivate people to change what they say and how they say it. Feedback literacy is also a really important part, so stay tuned for that. More to follow. Simulation helps us bridge these 2 worlds, and I think there's so much potential here to help our learners move from simulation to workplace. And an example of that would be to simulate the telephone conversations I highlighted earlier. And the other thing that really comes through loud and clear in both of these areas is the why. Share the rationale for the why in your conversations. Elicit the why in the conversations. Share your why in the conversations. All of this, I think, can promote shared understanding and shared learning. So future directions. we need to clarify more fully how simulation works, and DBR is one strategy. We need to learn from the workplace to inform simulations that promotes transfer of learning to the workplace. Feedback literacy, as I've highlighted, has a great potential. And I think we have lots of opportunities to optimize high stakes professional communication training, meaning when conversations matter. And I think team inclusive behaviors are vitally important. And I have a whole research program focused on that: interprofessional collaborative practice, and of course, peer learning and peer coaching. So in summary, talk is more than competency. Talk drives learning. And I hope with that, I will end and just thank my research collaborators and my dear colleagues from RCSI, including Dr. Claire Condra and Dr. Claire Mulhall, and the rest of the research team. Thank you. And I'm happy to have questions.
Good morning, Walter. Can you hear me?
I can.
Hi, it's Chris here from CAE.
Hey, Chris.
How you doing? I'm on the roving mic, so I'm going to open it for questions, and I will take you over if anyone has a question. So hands up,
Great.
please. Okay, heading to the front. Thanks for your time, Walter. Really appreciate it, especially the time difference in mind.
No, it's a pleasure. Thank you so much.
First question.
Thank you, Walter. Brilliant and inspiring as ever. I'll try and get my words right. I want to note, first of all, how you were able to give this presentation, and clearly care and learning are changing. And here at HPSN, we've seen the cutting edge of that in augmented reality merging into simulation. Do you think, I sense a quantum change. Do you feel that this approach will inform how we are rapidly changing at the moment? And will it survive it?
Will what survive it? If you could just clarify, please.
This artistry around debriefing and feedback.
Mm-hmm. I mean, I would say I hope it does. You know, at its core, what all simulation is about is how we as human beings engage with our patients and with other health professionals. And I see great potential in these advanced forms of technology enhanced learning. And I think we need to keep in mind that these are all proxies for what are highly social interactions. And I mean, I would say that those are one of the challenges. And I think that's one of the opportunities, is as we advance the technology, that we keep pace with the other aspects. I mean, one of the things I did not talk about here is a paper we wrote last year about virtual debriefing, and we used a so-called communities of inquiry framework to think about how can you promote the same degrees of psychological safety and learner engagement and the like in a virtual environment. And that's just a simple example when all of the learners are sitting on a video conference. But I think we need to have that same deliberate approach when we're looking at all of these other technologies where learners may not be co-located in the same place and may be engaging in virtual simulations in even different countries, right, or different time zones. But how do we keep that human touch in there? I would argue that's still vitally important in my mind.
Thank you, Walter. Second question.
Thanks, Walter. That was an amazing talk. It's changed my it'll change my simulation practice anyway. The telephone conversations, we have them often, but we don't debrief appropriately, I think, around them. So thank you for that. My question to you is about the SBAR format. It's certainly prevalent in Scotland. Whenever I ask people about it, they say that's what they use when they're doing a handover. They use the SBAR, but they don't. They never do an SBAR. But it's what's being taught and what people say that they do, but they don't do. And I just wonder, so then I try and reinforce SBAR and tell people they should be using that in practice if that's what they say they're going to do. But should I be doing that, or should I be telling them to use something else that they actually will use in practice?
Mm-hmm. Well, that's a loaded question, but I appreciate the question. And I think, if your health system, and and I know if you're from Scotland and you probably work very closely with Simon Edgar, who, by the way, I should have been visiting this weekend. I'm a little heartbroken about that. But, I think it's interesting, but SBAR is often about if I'm calling someone, I should use SBAR. But I don't think we really train up the listener or the receiver to extract the SBAR from the other person at the other end of the line. So there's something about co-construction of this conversation. I think if we train, and I know very often nurses are trained to use SBAR because so that they're complete in their communication, but yet we're not training physicians to listen in a way that would help and support nurses to use an SBAR format if that's what's valued in your health system. So communication is a two-way street, and pick whatever format you're going to use. If it's SBAR or whatnot, what I'm more of a fan of, it's not either SBAR or another framework, but it's about everyone understanding that it's not only about the person who's using SBAR to convey their information, but it's also about the listener. And so one of the things my work has really highlighted is that as a person who's engaging in a telephone conversation, if I'm calling you up and I'm sharing information with you, I need to share it in a way that you will hear it from me. I need to say the words that will grab your attention. And obviously one of the problems, I think, is that if the listener is not buying into the SBAR thing, that is a problem, right? Imagine a world, though, when someone calls me and they're nervous and they're trying to apply SBAR and they're rambling, and I say, hey, listen, can I just pause you for a second? Can you just tell me what the situation is real quick? Let's just go through the SBAR really quick. What is the situation again? And if I were to pause and sort of help extract information using that format, I think that would go a long way. So there's, to answer your question, I think both parties need to be buying into it. If it's just the person who's doing the phone call, it's not setting it up for the success that it would, and the success that it could have. Thank you.
Thank you, Walter. Third question.
Thank you. I was just wondering that within your research, have you ever looked at whether it's personal knowledge of the person that's making that phone call and that communication as well? So whether they've had a handover before where they've gone and it's been an emergency, or whether they've had a handover where they felt it was an emergency, so they've turned up, and then when they've got there, the situation wasn't as bad. So as the confidence in that information sharing?
Thank you for the question. And it's echoing again. Thank you for the question. I will say that was one of the things that came through loud and clear in a lot of the interview data that we did, and in some of the other research that we're working on right now around entrustment. If you have an established relationship and rapport with people, you've worked with them over time, you know what they need. So there's something very much about these longitudinal relationships that enable the communication to happen. Just to give you an example, like one data point that jumps out in mind is someone who was a critical care, pediatric critical care fellow, so a registrar focused on critical care, described a situation where a resident physician or an SHO who she highly valued and trusted, and they had grown close during the SHO's rotation onto the ICU. The resident called to say, listen, I've got a kid who is really sick, and the person was like, I'm coming right now, don't even bother, I'll be right there. So it's that sort of relationship and trust, and sort of and putting a lot of credibility into what the person is telling you, that is vitally important. And I think in my own PhD work, we really unpacked a little bit more, at least in the discussion chapter, about how the way we speak imbues a sense of competence, right? If you're rambling all over the place and including all of the relevant information, but also so much irrelevant information, but it's unstructured, I don't think you're competent, right? And so if I know someone and they're communicating clearly, then I view them as a more credible source of information. So I think those relationships are vitally important. And there's a lot of work to show also that longitudinal clerkships, for example, instead of being, at least in the United States, they would be for like 4 weeks at a time or 6 weeks at a time. Now they're over many, many months. You get to know people very, very well, and you get to know their idiosyncrasies and their quirks, and you know how to tailor your communication to them. So I just really appreciate your comment, and I wanted to just amplify what you were expressing. Thank you.
Thank you, Walter. Very conscious of the time. I will just mention that some of the RCSI colleagues that Walter mentioned are actually here in the room. So obviously after the keynote's finished, if you do want to further the conversation about some of the research, I'm going to embarrass Claire Condren, who's sat next to me here in particular. Please feel free to chat with her.
Well, and if I could say that would be great. And please approach Claire for anything that you're thinking about peer learning or peer learning in undergraduate education. I'm very keen to, advance that work that Claire is so passionate about. So that's something we're quite interested in. And if we could identify some collaborators in that space, that would be quite remarkable. I hope that's okay, Claire. I can't see you right now, but I think that would be a lovely thing. And I know you have so much passion around that. And Claire and I just wrote a book chapter about communities of practice that's all about this interactional form of learning, relational form of learning. So thank you for that.
Okay, lovely. So, well, on behalf of everyone at CAE, thank you very much for joining us, Walter, especially in the circumstances and the time. We thank you very much, and we shall leave you to get some rest.
Thank you so much, and thank you all for your support.